Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you, and we aim to take around 15 to 20 minutes. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Welcome to part 2 of the sternoclavicular joint with Dr Angela Cadogan. In this episode, we talk about imaging of the sternoclavicular joint and treatment options for physiotherapy. Enjoy. And where's the role of imaging here?
Yeah, well, that's interesting. So imaging has a quite important role, really, regardless of whether there's been trauma or no trauma. The difficulty we have is, as physios particularly, we can order x-rays and ultrasound scans. Ultrasound scans are virtually no use whatsoever for the sternoclavicular joint, but then the x-rays are, even the radiologists will say that's a good start point, but the x-rays of the sternoclavicular joint are very limited in even being able to visualize it very well, because you've got so many overlying ribs that you can't really get a good view of that joint. There is a special view which is called the serendipity view, which if you're referring someone for a sternoclavicular joint x-ray, then if you say it's sternoclavicular joint, most of the radiologists will know to do that, but it doesn't hurt to put that on the referral anyway. That's just where they angle the x-ray about 40 degrees upward, just to get a bit more of a view of the profile of the joints. You've still got the ribs overlying, but you can see if there's anything sort of major going on. So for physios, that's probably about our limit for imaging. Generally, if they're looking at with the traumatic injuries, the instabilities, if they're trying to see whether it's sort of anterior or posterior, if they're trying to see whether it may be a physeal injury. So quite often you can have what's called a pseudo dislocation in the sternoclavicular joint. So that's anyone under the age of about 25. So before that medial physis on the clavicle actually fuses, that physis is actually prone to fracturing. So it looks like a dislocation because it might sort of pop forwards or backwards, but in actual fact, the joint ligaments are intact. It's just that that growth plate has fractured and displaced accordingly. So that's another thing that they would image usually with CT scan to try and see whether they're dealing with a fracture or a dislocation or a physeal injury. If they're looking at soft tissue, so if they're looking at the articular disc, if they're looking at the ligamentous structures or the mediastinal structures in behind it, usually they'd look at doing an MRI scan for that. So yeah, none of those we can really order as physios, but that tends to be what they're doing to look at the traumatic injuries, but also the ones that we see through the hospital. Quite often we're ordering CT scans or MRI scans just to see whether there's what they call any mass effect. So whether the osteoarthritis or the joint changes are compromising any of those mediastinal structures in any way. So that's usually the high-tech imaging needed for that.
I'm just thinking, it makes me think when you have like these physeal injuries and there is effectively the fracture and the displacement, what's the treatment there? Because as soon as you intervene, you're going to upset the growth. Like, what happens for those young people?
Yeah, well, that's very much an orthopedic question. And from what I've read, I mean, I don't see them very often, but from what I've read, they do tend to try and do a closed reduction. So they do try and reduce them as much as they possibly can through closed methods. And then from just talking, this is very informal conversations I've had on the rare occasion that you do see one, they say quite often they will just leave them then and just see what happens. And if over time they'll put them in a sling for sometimes, 4 to 6 weeks. Sometimes or in many cases, that will just start to heal, and there may be some mild deformity, but it doesn't sort of go on to affect them unduly. The difficulty is that most of the growth of the clavicle happens at that medial growth plate. So I think if you were talking orthopedics, I'd be certainly asking a pediatric orthopedic specialist, what they would do about those sorts of injuries. So if you do see one, if you're dealing with children's sports, or when I say children, anyone really under the age of 25, so before that medial physis actually closes, and you refer them for an x-ray and they come back and say querial physeal injury, then I would certainly be getting an orthopedic opinion on that.
Such an interesting joint, isn't it? Because I was just thinking through that assessment, you have all these rotations of the joint, and then in different dimensions, with elevation, depression of your scapula, but also then rotation along the longitudinal axis as well, with your hand behind your back and all those sorts of things that can all place then stress on the joint. I think as we've been chatting, or I've been listening and learning, I've been thinking really around classification of the sternoclavicular joints, because broadly speaking, if I think back through my clinical patients that I've seen, they're broadly speaking either quite stiff and osteoarthritic, maybe not only the osteoarthritis, but perhaps some of these other arthropathies that we talk about, or they're unstable and they are moving more. Is that a fair classification? I didn't talk to you. I was going to say about classifications, but if I think broadly in my patient load, that's what I think I've seen.
Yeah. And I think I would totally agree. And I think they're either stiff or they're unstable. And it's very much like, the glenohumeral joint or the AC joint as well. So that's a very good way of classifying them. And even within the instabilities, I think I know you will be very familiar with it, and probably most people listening, the Stanmore triangle of classification of shoulder instability. So we tend to think about that more as sort of glenohumeral instability classification, but it actually fits very well with the sternoclavicular joint, and probably to a slightly lesser extent the AC joint as well, where if you're looking at what are the drivers of the instability of the sternoclavicular joint, either it's traumatic, so they've had some sort of ligamentous injury, so it's structurally compromised. It's the polar type 2, so that's kind of the bottom right of the triangle, which tends to be the congenital atraumatic instabilities. And I guess in the sternoclavicular joint, people who are hypermobile or have a lot of laxity in their joints, the sternoclavicular joint is another commonly affected joint in that patient group. So it can be just part and parcel of a hypermobility disorder. And then the polar type 3 is the muscle patterning. And those are the really tricky ones. And it's the same, it tends to be the same dominant muscle groups that affect the glenohumeral joint that can affect the sternoclavicular joint. And if you look at what muscles attach to the clavicle that might drive a sternoclavicular joint instability, certainly that pec major is one of them. And the more that is pulling on that clavicle, then that can certainly disrupt that sternoclavicular joint. Same with deltoid. I think in the glenohumeral joint, you sometimes see people who are very deltoid dominant, and that can cause a lot of shear on that glenohumeral joint, but that also attaches to the clavicle as well. So if they're very deltoid dominant, or there's any abnormal sort of motor control or muscle patterning around that muscle group, that can affect the sternoclavicular joint too. So it's often the same mechanisms, either trauma or hypermobility or abnormal muscle patterning that drives that instability. So the treatment therefore goes back to addressing the motor control aspects of that person's movement.
Yeah, and I think I've seen clinically like a really predominant or lots of activity, shall we say, in sternocleidomastoid as well, sort of pulling them. And I start to think more about deep neck flexors and trying to stabilize cervical spine so that they're not so much hanging on that would cause because some of those presentations all sort of coexist, don't they, with the upper cervical pain with some of that pulling and then traction through to the SC joint as well. So much to think about, isn't it, in that space?
And I
So,
think, I mean, that's a really good point you raise, because if you look at treatment, probably that would be the other other aspect of treatment that probably differs probably a bit even from the AC joint and glenohumeral joint, is
mm,
because of that sternomastoid attachment to the clavicle that can be associated with a raft of other upper cervical headaches, migraines,
yeah,
sternoclavicular instabilities. I've got one patient at the moment who's under a mandibular specialist, I think, for a TMJ problem,
wow,
which,
yeah,
when she's got a sternoclavicular joint problem, cause or effect, I don't know. But either
mm,
way, that's where you can often pick up, if you're looking at those muscle attachments broadly, including sternomastoid, assessing all of those muscle groups that we've talked about for muscle length. So are they
yeah,
tight?
yeah,
And then muscle activation and muscle function. Are they actually able to switch those muscles on at the right time and
mm,
in coordination with all those other muscles around it? So looking at sternomastoid length, sternomastoid strength is another one as well,
mm,
and deep neck flexors, cervical spine posture, which then ties into the thoracic spine posture, and then the
yeah,
scapular function. So it's all interlinked, and one leads to the other. Sometimes it's hard to know where it started and whether the sternoclavicular
yeah.
joint's sort of the victim or the culprit, but you've got to look at all of those factors with these patients.
Do you have any advice then, perhaps for younger clinicians? Because we've just covered and all, I mean, there's some fabulous little tips there, isn't there, for things to check. Make sure you don't miss this, make sure you don't miss that. But do you think that clinicians are then in danger of heading off down the rabbit hole of that's not sternoclavicular focused? Or you think we need to address all these other factors? Do you hear me? It's like when we were
Yeah,
doing core stability for and switching on our trans abs for things that were way distal to that.
yeah,
What are your thoughts there? Where,
yeah.
how focused should we be, and how far should we spread?
Yeah, that's right. Well, I think probably if we're looking big picture, assume that we've done our assessment and we've decided it is the sternoclavicular joint that's causing the pain. Okay, so
Yeah.
we've assumed we've ruled out our red flags. We're treating them as physios. There's nothing nasty going on. Everyone's ruled out everything else and they're back to us. So what I tend to look at then, firstly, is how big of a factor is pain? If the pain in the joint is the overriding factor, then no amount of motor control or muscle strengthening is really going to have much of an effect until you reduce that pain. So to me, reduce the pain by all the things we do, modify their activities, very short-term, temporary, sling for a couple of days if you need to,
Mm,
just to settle things down. Anti-inflammatories, talk to the doctor about medication, review that. Corticosteroid injections, sometimes they will inject those joints with corticosteroid, which can have quite a good effect as well, but you've
mm,
got to manage the pain. So that's the start point. From
mm.
that point, I actually use the symptom modification, sort of a whole series of tests to help me decide where to start,
Okay.
because we can look at all of those things and find 100 things to treat, and we've only got,
Mm.
20 minutes to do it. So where are we
Yes,
going to start?
exactly what I was starting to think as we were talking about all
Yeah,
these things that we need to check, isn't it? Because in the reality of clinical day-to-day life, they're here for 20 or 30 minutes and then they're gone again
that's
for
it.
however
And
long as your diaries permit.
that's exactly right. And that's the reality. We're time
Mm-hmm.
poor and we've got to do the best we can with the time we've got. So, and to be very honest, like, these patients might take 2 or 3 appointments to really get a good handle on all of these factors.
Yeah, yeah,
So I think your first session, you might be just doing well to get to a diagnosis. Then you might need some imaging. If they come back, then you can start. My advice would then be maybe start to look at some symptom modification and just
yeah.
see what's going to give you biggest bang for your buck as far as where do you
Mm,
start your treatment. So with someone like that, often elevation of the arm is an easy one that usually provokes the pain for most people. So what I will do is just start from the top and I'll just do a postural correction. So I'll get them to do a chin retraction, repeat the
mm-hmm.
movement. Does that help? Yes or no? If it does, I'm then going to sort of, in my mind, I have a bit of a flow chart. I'm going chin retraction. Okay, what do I have to look at? I have to look at the mobility of the cervical spine itself. I have to look at maybe the length of some muscle attachments around there, which would be the
Mm-hmm.
sternomastoid particularly.
Mm-hmm.
I need to look at the strength of the deep neck flexors. So we know that correcting the chin has helped the symptoms. Let's go down that, see what impairments we can find that we can then actually treat. If that makes no difference, I'll do the thoracic extension, the sternal lift, same process. Do we need some thoracic extension, stretching, etc.? I'll do the scapular correction. If that makes more difference to them, then I know I have to then look more at the scapular position, the scapular muscle function. Are they too dominant in some of their patterning muscles, the pec major, the lat dorsi, the rhomboids, the deltoid, levator scap? Look, at they working too hard? Are some of those other muscles not working enough? Are they not working as well in their upper traps, their serratus anterior, middle, lower traps? So I do tend to that's probably a good way to look at it, I think.
And I was just thinking what I might do is put together some of this through an algorithm, unless you already have one that I could make available for people to download, because I think it's a really nice systematic way of working through that about what's most important here for the patient in front of me. I just wanted to ask you, I have tried, you talk about trying to remove the pain, and I have tried sort of taping the SC for, I've seen quite a few of those anterior subluxations. They had sort of some help, but do you have any tips in that? Because you talk about putting them in a sling, but didn't no I can see that's okay. I just tried.
I wish I could, because those anterior instabilities do tend to be notoriously recurrent and very difficult to manage, and it's just not an area that's lends itself to wrapping tape around it to stabilize it without strangling the patient. It's just not possible to do it. But quite often what I will do is, if you can manually stabilize the clavicle while they're moving and it makes a difference to them, what I have found, if you then are looking at what we've just talked about, like the cervical spine, and you found maybe sternomastoids a bit tight on that symptomatic side, often when they're doing things, I'll get them to actually stabilize it themselves. So if they are stretching their sternomastoid, I'll get them to just stabilize with their other hand, just using their thenar eminence. Taping across the sternoclavicular joint, really difficult. Sometimes they have put, I don't know whether they still do, but they used to put people in those figure 8 sort of posture braces. My feedback from patients is they'll tolerate it for maybe a few days or a week, but then it just starts to get really uncomfortable. So that's something that you could try. I sometimes find I have a bit more luck, even though it's not taping for stability, but just taping around the scapula, just to try and sort of reinforce a good scapular position, so that they're not getting into those sort of concertinaed or protracted positions that might annoy that sternoclavicular joint. So it's more proprioceptive taping on the scapula, but it's really hard to tape it for stability.
Yes, tricky. And so then, is there anything else you wanted to add in treatment-wise that you think's useful for clinicians to think about? I think we've sort of talked through how you would prioritize that, And
no, I think we've sort of covered most things. I'll probably think of some things after we've finished, which I can flick you away if I do.
Flick me away, and I'll just add them into the notes for people to read when they get out of the car, of course. If they're listening to this in the car. Is there anything else you wanted to add while we're talking sternoclavicular joints? Anything else you think would be useful, or little clinical gems that you have for clinicians?
Not really. I think always a big thing with sternoclavicular joints is patient expectations as well, and just around time frames. And I think that is a massive one. Well, with all shoulder conditions, nothing in the shoulder is quick, but the patients just have to understand how long it might take, especially if you've got someone with multiple impairments that you're going to treat over a long period of time. It's going to take weeks and weeks to even get ADLs comfortable, let alone I went through a phase, was it last year or the year before, where I had 2 or 3 in a row, really, really tiny girls, quite hypermobile, doing they don't call it pole dancing, there isn't anything right now, but doing the pole sport where they're doing it for fitness, and they were wanting to sort of hang off bars and prop themselves upside down with these unstable sternoclavicular joints. So they just need to understand that they're going to have to find an alternative form of exercise for a period of time while you go about addressing all the strength and the function around that area. So I think patient expectations, certainly if there's any concern about the red flags, I'd always get them medically reviewed. There's lots of lab tests that are often needed to rule out that stuff. So refer those on if you're not sure. And just looking around that scapular area and the muscle function, again, like we talked about with the AC joint, the upper trapezius function is really key for that whole clavicle movement to then drive good scapular movement. And that's the one thing that I often find within my patient group that I see, which is only the ones that haven't come right with everything else, is that they're just not working their upper trapezius well. They're not getting good scapular sort of upward rotation with upper traps and that whole force couple. So that would be the other thing I think to really look at with those patients.
Yeah, cool. Hey, well, great as always, and thanks so much for your time this afternoon. That's been absolutely splendid. I knew there were going to be so many gems that you could share with people. So remind people they can meet with you then through your Shoulder Academy and through Physio Academy. Do you want to just remind people?
Yeah, so I do have a Shoulder Academy, which is a sort of an online community of anyone really who's interested in shoulders, which the website for that is shoulderacademy.co.nz, and it's just a monthly small subscription fee. We do Q&A sessions. We've got one coming up shortly, I think in the next month or so, about the AC joint, but we do cover SC joint as part of that. And I have got an online course actually on the sternoclavicular joint, which is available on Physio Academy as well. So that's physioacademy.courses, and just search for sternoclavicular joint if you're interested in that one.
Yeah, great. So there's a lot more information they could access then through those online forums for you. So
absolutely,
cool. Cool. Hey, well, thanks very much for your time, Ange. Great as always.
My pleasure. It's been great fun, Margie, and good on you for starting up the Glenohumeral Gurus podcast. I think it'd be a great thing for people to listen to. So really enjoying it.
Thanks for your contribution.
My pleasure.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.